Hello.
Yeah. Good
Yeah,
evening.
doctor.
Good evening. Sir.
Good
Yes,
evening.
yes,
Good evening. Sorry,
Yeah.
I
yes.
got late.
You can share your
No issues,
presentation,
sir. No
doctor.
issues.
Just 1 second.
Yes. So, good evening, team. Good evening, one and all. So, today here we have with us Dr. R.M. Manikandan. He's a
You can now start, Tulika ji.
okay. Okay. Good evening, team. Good evening, one and all. So today here we have with us Dr. R.M. Manikandan. He is a renowned endocrinologist from Madurai region. So today he will be sharing his meaningful insights on type 2 diabetes and cardiovascular disease, a serious complication. Over to you, sir. Kindly share.
Thank you. Can you see my slides?
Yes, yes, sir. Yes, sir.
Okay. Good evening, everyone. I'm sorry about the delay in joining the meeting. So there was an emergency. So thanks so much for the opportunity to talk about this important topic, type 2 diabetes and cardiovascular disease, a serious complication. Because the worry about managing diabetes is to people die early from cardiovascular disease. Both heart attack and stroke is very common. They also develop peripheral vascular disease. So that's the reason why we need to worry about poor diabetes control. So when we improve diabetes control, we know that the microvascular complication, retinopathy and nephropathy gets better. Until recently, the older medications, they did not have an impact on cardiovascular disease. But with newer medicines like sitagliptin and dapagliflozin, the improvement is much better. That's the reason why we are going to have a talk about how the newer molecules are improving the cardiovascular complications. So we all know that hyperglycemia is one of the driving force behind the increased risk for developing cardiovascular disease. So this is from the landmark trial, UKPDS trial, which shows that unless diabetes is well controlled, both macrovascular complication and microvascular complications goes up. When HbA1c moves from 6%, less than 6% to more than 10%, they noted that the myocardial infarction rate goes up by twofold. The main reason being insulin resistance is a main reason for hyperglycemia and can also worsen the um, uh, complications in the are associated with macrovascular complications like heart attack and stroke. When someone has got hyperglycemia, that itself can cause worsening of inflammation, oxidative stress, and can also worsen the hypercoagulable state, which in turn can increase the risk for developing cardiovascular disease. And when someone has got high sugars along with hypertension and hyperlipidemia, they also increase the risk for developing cardiovascular disease. So when someone has got obesity as well, that also independently increases the risk for cardiovascular disease. So we need to manage when someone's got diabetes, not only the sugar levels, but also look into the other parameters associated with increasing the risk for cardiovascular disease. So now we call this overall care as managing CKM, which stands for um, coronary, kidney, and metabolic syndrome. So when we manage all these three conditions together, cardiac, kidney, and metabolic combination, we're not only going to get good diabetes control, we are going to reduce the cholesterol control, we are going to reduce the complications associated with diabetes, both cardiac and kidney. This was coined by one of the cardiologist in his yearly presentation. So to overcome this, they have classified CKM as stage 0, stage 1, stage 2, stage 3, and stage 4. Stage 0 is before they develop any complication. Stage 1 is at the uh, beginning stage when someone is just obese. And stage 2 is when they start developing diabetes, hypertension, and hyperlipidemia. So that's when we need to intervene. Ideally, we would like to have all our patients in stage 0 before they have developed any problems. Stage 1 is when they have the pre stage, when there's someone is obese alone. There we need to concentrate on lifestyle modification. If someone has developed metabolic syndrome with increased central adiposity, increased hypertension, increased lipids, increased glucose levels, then we need to ensure that it's brought down by good lifestyle changes. And if needed, we need to use pharmacotherapy for uncontrolled blood pressure, glycemia, and lipid control. We need to also bring the hypertension and hyperlipidemia under control. If lifestyle is not sufficient, then we need to go for therapies to bring it under control. And for stage 2 CKM, diabetes management, main thing is lifestyle modification with weight loss, stress management with good blood pressure, good sleep, and smoking cessation. Ideally, we would like the HbA1c to be less than 7 and blood pressure less than 130/80. People should be on statins. And if blood pressure is not, blood sugar is not controlled, cholesterol, LDL is not controlled, ezetimibe can be added on. Preferably, we need to use therapies to protect the heart and the kidneys. So the recommendation is to use SGLT2 inhibitors with proven cardiovascular safety, along with other cardioprotective agents like GLP-1 analogs. So this is from the American Heart Association. The presidential advisory came in 2023. This is where all the guidelines have come out from. And for hypertriglyceridemia, as we said, lifestyle modification. And if it's more than 500, we try to add in medicines, including the newer drugs, the pentanoic acid, EPA, along with other lifestyle modification. Because lots of times, high triglycerides is a marker of poor diabetes and poor metabolic control with hypothyroidism. So managing them itself will bring it down. If it's not sufficient, then we add fenofibrate or these newer molecules. For hypertension, along with lifestyle modification, smoking cessation, regular exercise, and if needed, we add in ACE or ARBs because they not only get a good blood pressure control, but also protect the kidneys and the heart. And when someone is already having moderate to mild CKD, we add in ACE inhibitors, SGLT2 inhibitors, or finerenone to protect them from worsening of their renal profile. And for diabetes, along with lifestyle modification, as we discussed earlier, we use therapies which has more multi-pronged approach to protect them from further deterioration. If unfortunately someone has gone to stage 3 when they have subclinical cardiovascular disease or subclinical CKD, then we go for more aggressive therapy. They have advised looking for calcium score in coronary artery CT scan. And if it's more than 0, they have advised statins. If it's more than 100, we can add aspirin to reduce the risk for atherosclerotic cardiovascular disease. When we look at heart failure, if EF is less than 40, ACE inhibitors, beta blocker, and SGLT2 inhibitors should be added on. If someone's got high risk for CVD, then we need to go in for therapies like here to prevent them for further progression. Unfortunately, if someone has gone to the stage 4 when they have developed end-stage kidney disease or end-stage heart failure or end-stage CKD, then we need to go for more aggressive therapy. For diabetes control, we need to aim for sugars closer to 7% without hypoglycemia. We need to use therapies to get the blood pressure, everything under control. So this is the algorithm, what they have said. So for adiposity, they have recommended using GLP-1 analogs and GIP, or if needed, combination therapies along with bariatric surgery. For hypertriglyceridemia, hypertension, and CKD, as we discussed earlier, use appropriate therapies. And for diabetes, they say for in patients with atherosclerotic cardiovascular disease, use SGLT2 inhibitors or GLP-1 analogs, SGLT2 inhibitors to reduce heart failure, and use this combination if someone's got high BMI, high HbA1c, and CKD. If someone's got heart failure, SGLT2 inhibitors is preferred. And along with SGLT2 inhibitors, we can add in GLP-1 analogs because they not only give a good diabetes control, but also the pleiotropic benefits of weight loss. And now we have trial data to suggest that semaglutide is also very useful for heart failure. So SGLT2 inhibitors have become the more important therapy for managing diabetes, and also because of the pleiotropic benefits with regards to reducing the heart and kidney complications. That's become the therapy for managing not only diabetes, but also proteinuria and CKD for any cause, and also for heart failure for any cause, even without diabetes when they have developed these complications. In patients with type 2 diabetes, it's become the most preferred therapy because it's oral and also causes protection to heart and kidneys. So these are the pleiotropic benefits with SGLT2 inhibitors. We not only get a good diabetes control, it also causes significant weight loss, reduction in blood pressure, reduces the insulin circulation. So thereby it protects the heart and the kidneys. But also they have noted that because of the work in the heart, it causes reduced heart failure because it causes increased natriuresis and reduction of the preload. It makes the heart to pump better. It also reduces the arterial stiffness or reduces the afterload, and mitochondrial dysfunction, oxidative stress all comes down. And various cardiovascular outcome trials have shown significant reduction with hospitalization for heart failure and also reduction in the cardiovascular events. And that's what they have shown in this data. So this is outcome trials, and with dapagliflozin, it's been one of the widely studied trial. In declaratomy, what they showed was that when someone has got established cardiovascular disease, there was significant reduction in cardiovascular event. But when someone just had risk factors alone, there was no reduction in MACE event, but heart failure reduction was significantly there. And kidney disease was greatly reduced, 24% relative risk reduction, which was statistically significant. So this showed that when someone has got established cardiovascular disease or when someone has got increased risk, it's a wonderful molecule to use. And in DAPA HF trial, when they used this molecule with or without diabetes with heart failure, it showed reduction in worsening of heart failure, and death from cardiovascular disease was significantly reduced, 17% reduction. So this was noted even in patients without diabetes. That's the reason why this molecule has been heavily recommended for using in patients with heart failure, even without diabetes. And also similar thing was noted in DAPA-CKD with reduction of proteinuria. DPP-4 inhibitors are another good class of drug, which has shown that it works beautifully with regards to good diabetes control. And also it doesn't worsen the heart failure. It doesn't worsen the cardiac problems, especially sitagliptin. So sitagliptin was the cardiovascular outcome trial was done with TCOS trial, and it showed that it's a very safe molecule to be used in a high-risk population. So this was all done in patients with established cardiovascular disease, and they showed that it was very safe to use. It did not increase any further cardiovascular event, suggesting that it's a very safe molecule to use. So these are the two preferred molecules now, gliptins and glifosins, to use. And sitagliptin and dapagliflozin is one of the widely studied molecule, which has become very easily available because it's become more generic and less expensive. So we use it widely, and we are seeing the clinical benefits now. Thank you so much for the patient listening. I'm more than happy to answer any questions if you have any. There are no questions. Can we stop the session?
Okay, doctor. We will stop the recording
Okay, thank you.
because the viewer link was separate.
Hmm.
No issues. We yeah. ठीक है.
Okay.
Okay. Can we close the Zoom
Yes.
link, sir?
Yeah. Thank you so
Okay.
much.
Thank you.